Okay, good evening, everybody. It's my pleasure to welcome you in this webinar, which is organized in cooperation between the section of pediatric neurosurgery and section of peripheral nerve surgery within the EANS. And I'm happy to have my co-chair Christian Heinen here. We have a very exciting lectures from four prominent speakers. The idea was to highlight some very specific features from neurosurgical point of view of neurofibromatosis, which is a very complex set of diseases. So I'm happy to start with a speech from a very prominent speaker, my dear colleague from our section, Professor Shlomi Konstantini. He's been running a huge neurofibromatosis clinic in Tel Aviv, and I'm happy to ask him for his presentation on optic path gliomas in kids with neurofibromatosis. Please, Shlomi.
Thank you. Thank you. Thank you. Do you see my presentation? Do you hear me?
Yes, we do.
Oh, wonderful. Thank you. Thank you, Radek, and thank you all the members of the section for giving me this opportunity to present our experience with OPGs. Because of time limitations, I've liberated myself from giving the larger, more detailed talk, which does appear already on the ISBN library, which is a resource that I strongly recommend for all of you interested in pediatrics to use. We have already close to 1,000 items on the ISBN library. One of the reasons we have such a big advantage and a large number of optic pathway gliomas is the Israeli International Neurofibromatosis Center by Gilbert. This was founded 15 years ago when I had the feeling that we have more OPGs than other places. We've put under one roof NF1, NF2, tuberous sclerosis, VHL, and other rare phacomatosis. We have about 2,500 patients under this roof. One of the big advantages is that we have children and adults, and my colleague Felix Buchstein is going to give his talk about the experience with adults. I personally have more than 200 optic pathway gliomas, and the other advantage is that we follow our patients forever, so very, very few patients are lost to follow-up. There are about 10 people in the core of this center. We're doing monthly meetings. This is hard work to keep this machine with so many patients alive. Remember that this is a multidisciplinary disease, neurofibromatosis, and many times it affects several members in families. Many of the families are poor families who have to come to the hospital back and forth. This is the Tel Aviv Medical Center, the Dana Children's Hospital where we work. We are an international department, and you're all invited to visit us in wonderful, wonderful Tel Aviv. The best source to learn about phacomatosis is the yearbook of Child's Nervous System in 2020. I edited this with the help of Martin Schumann. There are over 30 chapters in this book. This book is also entirely already on the ISBN library. And the other yearbook that just came out in 2024, the Child's Nervous System yearbook on PLGG, pediatric low-grade gliomas. There is some overlap between this and the oncological side of phacomatosis. I did this together with Martin, again, who is a wonderful guy, and with Eric Buffet, that I'm sure most of you know. Again, over 30 chapters that are all inserted already into the ISBN library. I like this photo. This is, I picked it up in the Prado in Madrid, and I remember this photo when there's so many questions being raised and so little answers. It would be so nice to have Jesus or anyone else to help you with the difficult decisions that we have to do, especially in phacomatosis and especially in NF. So This is the most primary neoplasm of the optic pathways. Amongst NF patients, it is common. Some people say 20, even 25% of patients. It's a mainly indolent cause, but this is not always true. I'll show you a few cases where it is not an indolent cause, and about half of the ones affected with pathway gliomas will suffer from clinical symptoms, proptosis, visual loss, optic nerve atrophy, but also precocious puberty and hydrocephalus. Do we have a good classification system? How to follow this patient, when and how to treat? Can we predict prognosis? This is a highly, highly heterogeneous disease. You see the bilateral optic nerve involvement with proptosis on the left side, and you see the massive posterior pathways involvement in a classical neurofibromatosis case. So we started in the 50s with the basic Dodge classification, which evolved into the modified Dodge classification. We have a new staging. I will show it to you. It's not been published yet. The Dodge is good only for research, poor correlation with clinical status and prognosis, and the modified Dodge is too complicated and has the same difficulties as the primary Dodge. So we need a better staging system. This is our proposal. First, neurofibromatosis, yes, no. Age at clinical presentation is very important determinant. And then the anatomy. Do we have involvement of the posterior pathways? Yes, no. Do we have involvement of the optic nerve? Yes, no. And the chiasmatic involvement has 4 stages, and of course the molecular markers. So this would be a grade 1 chiasm confined. This would be a grade 2 chiasm and above. This would be a grade 3 chiasm above all the way into the third ventricle. And this would be grade 4. This would be an optico hypothalamic tumor with major supra and paracentral involvement, many times with cysts on different sides. I want to show you this case. This is a 15-year-old that I treated about 20 years ago. He was blind at presentation. He never complained. It's a Russian boy. They don't complain. So he just managed to be an excellent student with one eye. And when you look at this, and is it really an optic pathway glioma? It's epicentered in the hypothalamus, but not only in the frontal and temporal lobes. So this is the intraoperative view, and you see that it has a touch upon the chiasm, maybe a little bit of invasion of the chiasm, but most of the tumor is actually in the subarachnoid space. Here is Maxim on the day after the surgery, and this, of course, was a juvenile pilocytic astrocytoma before and after the surgery. So I left some tumor behind inside the chiasm, and this little tumor never grew for 26 years, no treatment. Some of the tumors are inside the optic nerves without chiasmatic involvement. We call them optic nerve tumors. When they're isolated, we call them IONJ. IONJ, I will show you an IONJ. This is isolated optic nerve tumor. And in this study, together with the Hopkins group, thank you, George, for helping in this study, and sick kids, this was published in Journal of Neurosurgery. I'll give you the highlights of this study. 34 patients who had only isolated optic nerve tumor, average diagnosis 6, average follow-up time about 6 years. 22 of them had neurofibromatosis, and the conclusion is that this is a highly active tumor, and about 50% will progress over time. Spontaneous regression is possible, but very rare. Devastating visual outcome. May respond better to chemotherapy than the general optic pathway gliomas. OPG exists also in adults. This is our series from neurosurgery, 22 adults with optic nerve gliomas. This is the publication from 2014, and the highlights. If you have an OPG from childhood, followed into adulthood, continue to follow because some of them may be stable during childhood and may grow during adulthood. Those that are diagnosed in adulthood, biopsy them because some of them are high-grade gliomas. So this would be a chiasmatic thickening. This would be major supracellular involvement, going up to the third ventricle, many times causing hydrocephalus that mandates a shunt combined with septum pellucidotomy and the posterior non-involvement. Neurofibromatosis complicates the situation because of NF spots, because enhancement can come and go. By the way, it doesn't mean anything, because the nerve sheet may be wide and also tortuous, and this is not pre-neoplastic. So, should we screen all NF patients? We start with basic neuro-ophthalmological exam, neurological exam, imaging, endocrinology, neurosurgical. This is a classical multidisciplinary team challenge. It's a slowly progressive disease, and one of the sins we're doing is to compare the MRI to the last MRI done 3 to 6 months before, where in fact we need to look at the outer perspective and see what is happening. How do we follow radiologically? It depends at which stage, every 6 months, every year, every 2 years. But how do we compare scans? This is very, very difficult, and the linear measurements are prone to error. For example, look at this scan, axial and coronal, where to put the line and how to do the comparison. So we have developed this 5-step method, and basically what we do co-registration of T1 and T2, then we do inter-scan co-registration because some of the MRIs are taken at different angles. And then we do baseline exam demarcation, automatic or semi-automatic demarcation. We look at the follow-up exam. We move the demarcation to the new exam so it's easier to see the changes over time. And the last step on this is the subsegmentation. The tumor is divided into solid enhancing, solid non-enhancing, and cystic. So when you sit in an oncology meeting, this is one patient, you see how the different subsegments are becoming over time with the treatments, and many times these patients get first line, second line, third line. What happens over time so you can make the decisions in a more structured way? NF is considered a better prognosis than sporadic OPGs. Posterior tumors are considered more radical, progressive tumors, and those that present at a young age. It's not always indolent. Look at this case. This is a 4-year-old male with NF1 and OPG on routine screening. Then he developed rapid visual and radiological deterioration within 4 months. He started with first-line chemotherapy, vincristine and carboplatin. It seemed to work, but developed severe carboplatin allergy. This was changed to second line with weekly vinblastine, but he continued to deteriorate with the vision. He was moved to an experimental protocol with rapamycin and Tasiva. And this is actually the patient I showed you before. He continued to deteriorate in his vision, and the tumor continued to grow. So this is what happened. The right eye from hand movement to no light perception, and the left eye from 636 to 6/216. He basically became almost blind. Interestingly, the Dodge and the modified Dodge classification did not change despite this rapid deterioration. So this is his scans. You see what happened over time. Becomes cystic, there is some growth to the sides, and he is practically blind. Who should receive treatment? Dynamic patients, we agree, but what do we do with patients who do have MRI changes but have a stable vision? This is an open question. Do we treat our patients too late? How to treat? We have in oncology the chemotherapy, the gentle chemotherapy, and the biological treatment. Radiotherapy, I'll talk in a second. Surgery, yes, no, and future directions. These are two landmark papers that were published last year on targeted therapy. Look at the right paper in the New England. This is the Eric Buffet group claiming that the combination of anti-BRAF and MEK inhibitors is more effective than any of them by themselves. Not all the oncologists accept those conclusions. What about surgery? Do we need a biopsy? It's a matter of debate. Most oncologists will agree to treat an NF patient with an OPG without a biopsy. Does it really matter, the morphology, whether it's a JPA, a low grade, and even a pilomyxoid, which has a big name? What about the chances to miss a germ cell tumor? This will probably not happen in experienced places. So the biological markers, yes, we need them, but maybe not at the first stage. Surgery, very poor data, very poor data. I would say that from 20 patients with an OPG, only one would be a surgical case. Here are a few examples. It's a 4-year-old boy with a sporadic glioma. I operated on him and I gave him some hemiparesis when I was peeling the tumor off the middle cerebral artery. So I left some tumor behind. He received vincristine and carboplatin, and that residual disappeared. It's a good case. Stable vision for 10 years. Maybe I shouldn't have operated on him at all. Maybe I should have started him on chemotherapy from the start. He is well and alive. Look at this diencephalic syndrome case of an infant, major suprasellar. It looks foamy and bubbly. And this is what we did in surgery. We came from above interhemispheric, and you see we left tumor behind because as you go down, you have no idea where the optic apparatus is. He's incredibly stable and treated with chemotherapy. And this case that I operated 10 times, look, we call it a cyst-loving OPG. He developed cysts with mucinous fluids, got a shunt, open, endoscopy, everything. The cysts keep coming back. So, do we need a biopsy in sporadic patients? Probably yes. Do we need a biopsy in NF? Probably no. Is early surgery beneficial? Probably no. What is the extent of resection? I'm not sure we need any resection. What is the role of surgery in optic nerve tumor? This is something to discuss. The first line is usually with vincristine carbo. This is the Becker regimen from almost 30 years ago. Second line, temozolomide, vinblastine, some other medications, and then, of course, the targeted therapy came in. Chemotherapy does not affect visual outcome. Very good. This is the first paper by Perilongo from Padua, and this is our paper showing quite a sad picture. We took 19 patients on treatment. 14 of them continued to deteriorate. 4 were stable, and only 1 improved. I personally believe that radiotherapy is underused with optic pathway gliomas. It's considered a no-no because of cognition, because of secondary tumors, and vascular sequela. What about losing your vision? That's not a very good thing to have anyway. And then there is a craniopharyngioma paradox. The oncologist will accept that in craniopharyngiomas, we can do a minimal or subtotal resection and give radiotherapy. But for OPG, they will never agree to give radiotherapy. The patient continues to deteriorate, first line, second line, third line, and almost blind. And then they send for radiotherapy, which is too late. This is the paper from Merchant from JCO with a stunning stabilization of vision in 2/3 of the patients. I think it's underused. Who should we irradiate? Is there an NF safe zone in terms of age? What is the role of proton beams? And what is the role of SRS? Just one last patient I want to show you. I've been following this patient from the age of 8, showing how old I am. It was a classical OPG. He was quite stable and then deteriorated quickly. He bled into the tumor. That happens, and this is after removal of the blood. This is him. This is the paper we published on bleeding inside OPGs. And here is Jesus among the doctors again to help us take the decision. Thank you very much.
Okay, thank you very much, Shlomi, for an excellent lecture. I suggest that we take all questions and answers at the end of the webinar. And as I've instructed the audience, please feel free to type your questions in the chat box, and we will read them after the last lecture. So for now, I ask my co-chair, Christian Heinen, to present the next lecture. Please, Christian.
So thank you very much, Frederick. And well, first of all, I want to thank all of you speakers, of course, the audience, and basically Radek and Anna organized this fantastic webinar. So I'm very happy that we, join the forces and take care of this very interesting and very challenging topic, as we just learned also by the fantastic talk of Shlomi. So in my schedule, the next would be George. Is that correct? Yes. Okay. So it's a huge pleasure and honor to introduce George Yellow from Baltimore. Baltimore, in terms of these pathologies, is, well, one of the leading institutions, and not only in the US. So we are very happy to have you with us and share your experiences and knowledge with us. You're still muted, George.
How's that? Thank you. Thank you all for the opportunity to speak about experience with spinal tumors and neurofibromatosis in children. And as much as I am in Baltimore, I spend more time now in St. Petersburg, Florida at the Children's Hospital. But still, as you can see, it is a 260-bed children's hospital that manages all aspects of pediatric care. So, I think when we talk about this, and I know Shlomi did a great job with the optic pathway tumors, I think, just as background, I think we all recognize there's three types whenever you say neurofibromatosis. There's the classic NF1 or von Recklinghausen's disease, which is the most common, and it's typically seen in 1 in 3,000 individuals associated with chromosome 17, and 30% or half may be spontaneous. NF2 with the with your bilateral, with your acoustic schwannomas or neurofibromas, lesser incidence, and the gene associated with that is chromosome 22. And then this relatively new entity that is called schwannomatosis, SWN, that is less common than the other two, and that's associated with mutation of the SMARCB or the LZTR1 gene. And each have their own presentation. The optic pathway tumors that Shlomi spoke about, we'll hear a little about the acoustic tumors, but they all have tumors associated with them in the spine. And here's a relatively new case I had the opportunity to manage. 17-year-old girl with known NF, not treated for the intracranial tumors, has just been followed for that. Did have a intramedullary tumor in the cervical spine that had been previously operated on, I think about 2 years prior, and she did recover, but then had this progressive myelopathy over the past several months' time that was rapidly progressive, including, besides having hyperreflexia, she was almost confined to a wheelchair, given the profound increased tone, as well as the spasticity in her lower extremities. You can see the intracranial tumors there, the convexity meningioma, as well as the acoustic, and a tumor meningioma in the ventricle as well. But really, this is what she had presented with. You could see the previous cervical operation for the ependymoma, but below the operative site, she had a second tumor there, and you can see it on the both the contrast enhanced sagittal as well as the T2 images. And then you can see that, this otherwise the remainder of the spine was relatively clean with that. When we look at this, you can see the extent of the disease. She had both extradural component and extraforaminal tumor, intradural component, as well as the intramedullary tumor. The extramedullary tumor was higher at C2 to C4, and then the intramedullary tumor was really at C6 to T1 level. And the question comes up, in decision making is, what is she symptomatic from? One, she is symptomatic. This is a young girl that was previously ambulatory and is now almost confined to a wheelchair. And one has to try to discern which lesion is causing her symptoms. And knowing that you could see the significant cord compression from the extramedullary tumor as well as the intramedullary tumor, we elected to address both the intradural extramedullary as well as the intramedullary ependymoma. And she did well following surgery and did require inpatient rehab following surgery. The ependymoma was completely removed. I would call that extradural tumor. I will say I was pleasantly surprised. I was thinking it would be a neurofibroma, but on pathology, it returned as a meningioma, which I had not seen before in this population. And we were able to achieve, we didn't get a gross total resection of the meningioma. Her dura was significantly involved. So we did end up leaving some residual there and elected to follow her. The next case is, this is a interesting case that I am managing currently. And the mother lives in Florida, but has sought several different opinions for the care of her child. And I just met him for the first time in November. 8-year-old boy that was slightly born premature with a diagnosis of cerebral palsy, who had a selective dorsal rhizotomy at age 2 elsewhere. And we don't have the imaging from that operation, and I'm not sure if any imaging was done prior to surgery. He was diagnosed with neurofibromatosis NF1 at age 5. And has been followed. Recently has been complaining of progressive leg pain and urinary urgency. This has progressed that he's almost developed some urinary retention. And you can see the extensive lumbar plexus neurofibromas that are involved with this child. And you can see some of the lumbar nerve roots being involved intradurally. But what the mother is most concerned about is this intradural extramedullary tumor at the cervical medullary junction. And you can see that there is a intralateral tumor that is extramedullary. And the mother has been adamant that surgery needs to be done to help her child. And the question comes up here in the discussion is, where is he symptomatic from? And if so, what can be addressed? I will say I met this child in November. I did not recommend surgery for him for this, and discussed with the mother that really his back pain and urinary retention now is from the lumbar plexus, the significant plexiform neurofibromas in the lumbar plexus, and that addressing this is not going to help his back pain nor his urinary retention, and that really addressing the lumbar plexus is such a profound tumor that there's really no role for surgery, and that the best approach is a chemotherapy option for him. So I think when you talk about the recommendations for these children with spinal tumors, it's one, just as Shlomi had said, just because it's there doesn't necessitate a surgical approach to it. There are other options to manage some of these patients. So, I think when we talk about NF1, this is the largest, component, and about 35 to 40% of them will develop neurofibromas in their spinal canal, and always recommend neuro access imaging at some schedule for these patients. There'll be very few, very few of them will have intramedullary tumors. Some may have bilateral neurofibromas, and that of these children, less than 2% are going to be symptomatic at presentation. And in our large population, in our multidisciplinary clinic, we really see, at best, given, of several hundred children and young adolescents that we're following, we may see 1 or 2 a year that are symptomatic from their spinal disease. This is a young male as well that, we had been following in our clinic, NF2 with known intracranial and intraspinal tumors. He too, again, presented with progressive myelopathy, both in the uppers and the lower extremities. And he was ambulating, although he had frequent falls. You could see this case, again, with the spinal element tumors, multiple spinal tumors that are extramedullary throughout his neuroaxis. He's got a cervical medullary lesion at the that is intramedullary, and then he's got some other intramedullary tumors in the cervical canal, but a profound, a large intradural extramedullary tumor from C4 down to about C7 with significant cord compression. And you can see it here. He's got both on the axial images. You could see he's got what we almost call kissing neurofibromas from bilateral foramen, as well as the intramedullary component as well. And given the profound progression of his symptoms, the recommendation was for a decompressive laminectomy to debulk the intradural extramedullary tumors, as well as, given the uncertainty if he's symptomatic from the intramedullary tumor, with these extramedullary tumors, to address both at the same time. So, looking at the literature, this is a recent publication that looked at intramedullary spinal cord tumors in this in the population of neurofibromatosis, and this was one of the largest series that I could find, and really. When they looked at their series of over 500 patients, both pediatric and adult, what they found was that in NF1, as what's written in the literature, astrocytomas were the predominant intramedullary tumor, whereas in the NF2 population,
I think we lost the George.
Yeah, I can hear it.
Yes. So should we reach the time with there's already one question in the chat?
Yes, why not?
Should we go for that while George reconnects?
Yeah, I think it's a good idea. So we have one question from Rim Fakak, asking Shlomi about the role of endoscopic ultrasonic aspiration in OPGs. I'm not sure if Shlomi is connected.
Oh.
Hello.
I think you lost me.
Yeah, we lost you. But anyway, we will finish your presentation before we continue. Please go on.
Okay, thank you. Sorry, let me get back to the presentation. Where is it? Sorry. So, when you look at the series, again, when you looked at their operative cases with NF1, really it was a very small, less than 1% had symptomatic intramedullary tumors in NF1, whereas it was a slightly larger percentage had ependymomas in the patients that had NF2. So extremely rare and unusual to require surgery. The other manifestation, this paper just looked at the types of tumors that you could see in the NF1 population and really addressed more of the paraspinal or extradural tumors in NF1. And then, I better not forget, but talk about spinal deformity that may be that is associated with NF1, and it's more likely due to extramedullary etiology for the development of spinal deformity in these children, just because there's a small intramedullary tumor that is not leading to their spine deformity. It's really could be associated with their bony or vertebral anomalies, and that should be addressed. So again, as another large series that looked at the NF1 population, and this is just shy of 500 patients. And what they found was that, it was really, the majority of the patients with NF had some dural ectasia, some abnormalities, some spine deformity, but the incidence of intramedullary tumors is quite rare. And that, the majority of the tumors was typically seen as a spinal nerve root, as you would expect, or a plexiform nerve root, and only 1% had intramedullary tumors, which is fortunate. Same thing in this review, albeit several years old, and their recommendation was that they really should undergo screening, but the incidence of spinal tumors in NF is rare, and that really, in asymptomatic patients, the decision to operate is really based on radiographic evidence or if there's real or impending neurological compromise. So really just want to conclude, although spinal involvement is common with these neurofibromatosis, the intramedullary location is very uncommon. And fortunately, the majority of the children and adolescents remain asymptomatic, and treatment is surgical when the symptoms are progressive. So I just want to thank you all, both the participants and the speakers, for allowing me to share my experience with intramedullary tumors in children. Thank you.
Yes, very nice. Thank you very much, George. And again, an excellent presentation. I think we will move on and we take all the questions at the end. So now I would like to ask our colleague Justus Groen from Leiden, neurosurgeon who is specializing in peripheral nerve surgery and brachial plexus surgery, with his presentation focusing on peripheral nerve tumors in neurofibromatosis. Please, Justus.
Yes, thank you very much for giving me the opportunity to give this presentation to you all. I changed the subject a bit. I pointed it down to the pediatric NF1 population, so not all neurofibromatosis, but only NF1, because I think that's the most challenging group. Let me see. Next page. Yeah. So I work in Leiden with the Leiden Nerve Group with Willem Pondaag, Professor Malessi, and I think it's very needed and valuable to have a network in your country or in Europe to treat these patients. So we have a Dutch NF1 expertise network where you have treatment centers and intervention centers, and also recently a cyber poly was started for children with chronic disease, and they can ask all their questions online in a cyber environment to all the specialists from this network, which is very helpful for a lot of questions asked, and they don't have to come to our centers. So no disclosures, all patients agreed to show these pictures to you guys. Neurofibromatosis was already presented on by the previous speakers. It's important that it's a rhasopathy, so it's a multi-organ disease. It has a complete penetrance, but it has a high variability in presentation. And of course, there's a high percentage with cutaneous neurofibromas, the name giver of this disease, and about half of the patients also have the plexiform neurofibromas I'm going to talk about in this talk. It's important to notice that 1 on 10 of these patients will develop an MPNST in later life, because it's also influencing your treatment of these younger patients. So the cutaneous neurofibromas, which are very prevalent, we're not going to discuss, but I just want to point out one thing, which is, I think, important and gave me some new insights during preparing this talk. The cutaneous neurofibromas have sort of 2 groups. You have the cutaneous neurofibromas, which are discrete in the cutis, but you also have the involvement of the subcutis and the skin by plexiform neurofibromas, which is a total different kind of problem. So the first, like cutaneous neurofibromas, won't come to the neurosurgeon, of course, but the other group definitely comes to us as well for treatment, and especially because of the disfigurement and the dysfunction by these sometimes large tumors in the skin. So as said, neurofibromas in NF1 children, 50% when you screen them with MRIs will have a plexiform neurofibroma. Just on examination, you see it only in 30% of the patients, so it's important also to screen them. 15% of these patients will have multiple plexiform neurofibromas, and as said, it's MPNST is a risk in these plexiform neurofibromas, and it's very rare, but definitely not impossible to get an MPNST in the juvenile patients. So as young, we've seen them as young as 4 or 5 years with MPNSTs. Most commonly, PNFs give problems in the 2nd decade, but also we see them younger and when they have large tumors in, for example, the neck. And symptoms are most presently the disfigurement, dysfunction, and pain. When you look at the group of young patients with plexiform neurofibromas and look at when the intervention was done, it's most often the craniofacial patients who have an intervention done. So especially the periorbital plexiform neurofibromas and the PNFs in the trunk and in the brachial plexus. They need surgery or other treatment. So what can we do when you find when we have a patient with plexiform neurofibroma? You can treat the pain, of course, with medication. Since 2010, we have a MEK1 inhibitor, which was found in 2022 and was also found useful by the EMA. So we can give these medication to the patients who have large tumors and try to treat this without surgery. But still surgery is a very good treatment options in these patients. And that's what we're going to talk about more, the surgery of these plexiform neurofibromas. The goal of this surgery is, of course, to protect nerve function and to get as much tumor out as you can without harming the patient. Indications for resection are, in our thought, signs of atypia, so a large, fast-growing tumor, high uptake on the PET scans, untreatable pain or loss of function are all red flags where you have to look into and find if you deal with an MPNST or atypical NF tumor. Also, pain is an indication for surgery when you cannot manage it. And in another way, disfigurement, dysfunction. And of course, when you have small superficial NFs where you can do a total resection, it's also a good indication when the patient wants this, because it's not very harmful and it's treating the complaints. So what we do as a workup, we take history, we do a physical examination, of course, MRI, ultrasound, PET scans if needed. And if you have, you think of atypia, we like to do a targeted large needle biopsy guided by the PET scan. So we decided to do surgery in this young patient. What do we consider the risks of this surgery? Well, in general, when it's more axial in the body, it's there's a higher risk of complications, so of loss of function. And there's a nice paper of Fisher where they have 3 groups of these tumors, make 3 groups of morphology, depth, and relations with adjacent tissue. And when you're on the left side with a diffuse, deep, and interdigitating tumor, it's more likely to have complications than when it's a nodular, superficial, and circumscribed tumor. And also the size, of course, matters. And if there's an when it's an atypical tumor, you want to take as much as possible, so it's a bigger risk of function loss after surgery. So there is, considering these risk factors, there is surgical morbidity in all these patients. And when you look at the larger series, you have surgical morbidity of around 40% of sensory loss and 5% of muscle weakness after surgery. And we all say when we do the surgery, it's not in our center, it's way less. And it's true that half of them recover to normal, but still there's a risk, especially in this patients with a higher risk factor. There is a loss of function after surgery in plexiform neurofibromas. So that's very good to realize that before you start this journey with the patient. You have to balance that with your effort to try to do a radical resection. When you do more radical resection, the recurrence rate will be lower. In general, there's a 25% recurrence rate of this plexiform neurofibromas, and it's more often in young patients when it's an axial location. When you do a partial resection, is also a risk factor for recurrence of these tumors. So my first take-home message is surgery is indicated for this plexiform neurofibromas when you have signs of atypia, when you have refractory pain, when you have dysfunction or disfigurement. And the goal of your surgery is protect the function and do a gross total. Surgery is, in general, it's a safe option, also in mixed nerves. You do it in a proper way, and the degree of resection depends on the site, the nerve, so which nerve it is, and the morphology of the tumor, as I just showed. And it's important to look at the nodules of these plexiform neurofibromas. And the nodules most of the time, can be taken out without any problems. Other considerations to keep in mind when you treat these plexiform neurofibromas in children, that there is another treatment option, which is the MEK1 inhibitor, which you have to discuss with your oncologist or neurologist. That there's tendency to start to do surgery earlier because the tumors tend to be easier to take out. Also to start MEK inhibitors earlier in life to prevent them from growing. And surgery is the only way to prevent development of the MPNSTs in these patients. So if you have larger tumors, it's to consider that you might do a preventive surgery. MEK1 inhibitors doesn't prevent MPNSTs. So how we do it? Well, you have your normal instruments. The most important instrument is, of course, your nerve stimulator, which is pointed out here. Microscope also, of course, important, but the nerve stimulator, without it, we don't go in. I have some cases which I like to present. So this first case is a 7-year-old boy with NF1, and he's a bit grumpy guy because he has a lot of pain in his neck and his right arm. There's a swelling which is growing. Otherwise, he's doing well, but he is in a lot of variable over the day, a lot of pain. So as examination, we feel the swelling above his right clavicle, no motor deficits or sensory deficits. And on the right side, you see his MRI with a nodule just superficial from the brachial plexus. So when you look at this risks classification I just showed, there's a brachial plexus, so it's quite high up in the risk list. However, it's a nodule and it's quite superficial as well, circumscribed. So we went for operation and we could take out this nodule without any complications. And at follow-up, you see there's still no regrowth of this tumor. So another case is a 16-year-old girl with NF1 with a pretty fast growing neurofibroma in the infraclavicular space on the right side, with especially mechanical problems because it was stuck under the clavicula when she moves her arm, but no loss of function. No PET scan was done or other imaging than we see here. When you look at this risk scheme, you're okay, but especially because it's quite circumscribed, and superficial. So we could do surgery and postoperative, like the picture on the right side. So we could do a gross total resection, but at the pathology or histology, it was atypical. It was a neurofibroma with atypia. So we just need to follow up her a bit more closely. Then the last case is a 13-year-old boy with NF1, a large neurofibroma in his left neck, running with the brachial plexus. And it was present since his fifth and progressive over time. There was no pain, but he had some numbness in his hand on the left side. And when we examined him, we found large lump, of course, and no motor loss of function. And to reduce tumor, we opted for surgery. There's no clear nodule, but it's a sort of more diffuse tumor. So it has a bit higher risk of surgery to have a loss of function after surgery. So preoperative are the pictures on the above, and below there's the postoperative imaging. So you can see there's some reduction of tumor load, but there's still, of course, a large tumor present. But especially the superficial part could be taken out with monitoring of the function of the brachial plexus, the accessory nerve and the phrenic nerve, and of course the artery and the veins in this area. So he's 18 years at follow-up now, and you can see there is some growth, especially on the back side. So you see on the right side, you see on his back near the scapula, there's a nodule growing, and he has a lot of discomfort from that. Otherwise, he's doing fine. So here, there's a nodule, and you could take out quite easily. You don't have to open. You don't have to go for the whole tumor. You just go for the part which is giving him the problems at present. Then we saw him again 4 years later, and the tumor, especially the supraclavicular part, was growing. He had occasional pain there, and it gave him no limitation in his life. However, he was bothered by the visual thing, so he didn't like his lump in his neck. So we did the assessment again, and because it's a secondary surgery, is an extra factor to be very careful. So we did a supraclavicular debulking, which was very hard to take away a lot of tumor because there's a lot of fibrosis. We used a stimulator a lot, but everything in this area stimulated gave a motor reaction. So only like a small part of the tumor could be removed. Otherwise, he's doing fine after surgery, but there was not much to be done without giving him loss of function. And because it's not an atypical or malignant tumor, we decided not to go any further. So to take home, surgery is indicated if there's atypia, when there's pain, when there's dysfunction, look for the nodules in the tumor, and consider also medical treatment with a MEK1 inhibitor in a multidisciplinary assessment of these patients with the oncologists. So this is our group, and I'd like to answer any questions when there are some. Thank you very much.
Thank you very much, dear Justus. Great presentations, like all the ones that we saw so far. And now it's our huge pleasure to introduce Felix Bockstein from Tel Aviv to show us with what we do, what we actually doing on the long run. So I'm very curious to see how the long-term effects look like. Felix, please.
Oh, thank you very much. Good evening. Thank you all to join us today. My presentation was announced to explore surveillance of children with NF1, but actually I'm not a pediatrician. All my professional life I am treating adult patients. For the last 25 years as a neuro-oncologist in Tel Aviv Medical Center. More than 2 decades ago, Professor Shlomi Konstantini, with whom we worked together for years, has founded in our hospital the Gilbert Israeli and International NF Center. And our center treats both children and adults with different neurogenetic disorders, and I am responsible for adult care. So in this presentation, I'm going to discuss the diagnosis and surveillance of NF1 patients depending on their age, with a special accent on the transition from the pediatric to adult care. I think we can skip the slide. It was already discussed. It is a very common neurocutaneous disease and one of the most common genetic diseases at all. So I just want to shortly to remind you the diagnostic criteria of NF1. The diagnosis of NF1 is done in accordance to these criteria elaborated at several consensus conferences. The diagnosis should be established if the patient has at least 2 of the following features: 6 or more Café-au-lait spots, freckling in the axillary inguinal regions, optic pathway glioma, 2 or more leash nodules, sphenoid wing dysplasia, or thinning of the long bone cortex with or without pseudo arthrosis, 2 or more neurofibromas of any type, or 1 plexiform neurofibroma, and a first-degree relative with NF1 diagnosed by the same criteria. Recently, a genetic criterion has been added: detection of a germline pathogenic mutation in the NF1 gene. This criterion alone is sufficient for the diagnosis of NF1. NF1 is a multi-system disorder, which may involve a variety of organs and issues. Skin features like Café-au-lait spots, freckling, cutaneous neurofibromas develop in the vast majority of the patients and serve as diagnostic criteria. Ocular manifestations are frequent and include leash nodules, which are an important diagnostic criterion of NF1 but do not interfere with ocular function, and optic pathway gliomas, usually developing in early childhood and having potential to cause severe damage of vision. Neurofibromas are the main feature of NF1 and may be cutaneous, subcutaneous, and deep-seated. Plexiform neurofibromas are usually congenital or develop in early childhood. In about 15% of patients, they may undergo during the life transformation to malignant peripheral nerve sheath tumors. NF1 belongs to cancer predisposition syndromes. Besides optic pathway gliomas, different other types of neoplasms may develop in NF1 patients. Most common kinds of tumors in NF1 are malignant peripheral nerve sheath tumors, non-optic gliomas, pheochromocytomas, GIST, and breast cancer. Non-tumoral neurological manifestations of NF1 are common and may be related to involvement of the central and peripheral nervous system. Learning disabilities and behavioral changes are typical for children with NF1. Intellectual decline and the autistic features are less common. Other neurological features include epilepsy. Other neurological features include epilepsy, headaches, pain, chronic pain, and other. Many NF1 patients suffer from musculoskeletal problems, which include long bones and sphenoid wing dysplasia, dystrophic and non-dystrophic scoliosis, chest deformity, and short stature. Osteoporosis may develop in adolescent and adult NF1 patients. Vascular abnormalities in NF1 include congenital cardiac defects, different kinds of NF1-related vasculopathy, Moyamoya disease, and stroke. Frequency of hypertension in adult NF1 population is higher than in normal adult population. Almost all clinical manifestations of NF1 are age-related. Many features start in early childhood or are congenital, like skin and ocular dystigmata, optic pathway gliomas, and big plexiform neurofibromas. As well, most neurological manifestations, learning disabilities, behavioral changes, intellectual decline, autistic spectrum disorder, are diagnosed in childhood. Dysplasia of the long bones or sphenoid wing is congenital. Dystrophic scoliosis due to vertebral dysplasia usually develop at the age of 6 to 10. Non-dystrophic scoliosis is typically diagnosed in adolescence. For many features like OPG and plexiform neurofibromas, the risk of starting in adulthood, if not diagnosed in childhood, is negligible. On the other side, there are manifestations that are typical to start in adult age. For example, cutaneous neurofibromas usually start developing in the puberty and continue to grow during life. Additionally, malignant tumors of any kind also develop in adulthood. This is another more schematic and more user-friendly way to demonstrate the age-related nature of most NF1 clinical features. Catheolus-exposed bone abnormalities and big plexiform tumors are usually diagnosed at birth. Developmental, cognitive, and behavioral abnormalities manifest at the ages of 1 to 5. Optic pathway gliomas, although sometimes congenital, are usually diagnosed at the ages of 1 to 10. Additional features, such as precocious puberty and Moyamoya syndrome, appear at the ages of 6 to 10. Adolescents are often diagnosed with non-dystrophic scoliosis and cutaneous subcutaneous neurofibromas. Typical features in adult NF1 population include slowly growing cutaneous and subcutaneous tumor, hypertension, malignant transformation of existing plexiform neurofibromas, other malignancies, and osteoporosis. Let's devote a few words to clinical picture of NF1 in adult population. I would like to stress again that most severe features of NF1 like OPG, big plexiform tumors, bone dysplasia are congenital or develop in childhood. The typical clinical course of NF1 in adult patients is usually characterized by a general, gradual increase in number of cutaneous and subcutaneous neurofibromas. Adult patients with big plexiform neurofibromas are at risk of transformation to malignant peripheral nerve sheath tumors. Other typical manifestations in adults include hypertension, which is common than in general population, osteoporosis, and osteoporosis-related orthopedic problems. Risk of development of any malignant tumor is increased in adult NF1 patients. Most common, again, cancer types in NF1 include breast cancer, pheochromocytoma, and GIST. Let's move now to management guidelines for diagnosis and surveillance in NF1 patients. So NF1 is usually diagnosed in childhood, but we still see sporadic patients who are diagnosed in adult age. Every person with newly diagnosed NF1 must undergo a detailed clinical evaluation, including physical examination, with a special accent on skin stigmata like café spots and freckling, cutaneous and subcutaneous neurofibromas. The patient should be examined by a neuro-ophthalmologist experienced in NF1. In elderly children and adults, the examination should include also visual field test and optic coherence tomography, OCT. Every patient needs a comprehensive neurological examination and evaluation of the neurodevelopmental status, cognitive, behavioral, and affective issues. The skeletal system must be evaluated to rule out the possibility of scoliosis, deformities of long bones, and the chest. In children, growth plots should be drawn. Evaluation of the cardiovascular system is also important, particularly in adolescents and adult patients. If the clinical diagnosis of NF1 in a child is undeniable, there is usually no need for genetic evaluation. However, in children with unclear clinical picture, molecular testing of the NF1 gene should be considered. Every adult patient of childbearing age with a new diagnosis of NF1 should be sent to the molecular testing and genetic counseling. Few words about, now about the surveillance recommendation. There are recommendations for surveillance of children with NF1. So the child should be examined in a specialized NF1 clinic at least once a year. Evaluation of the neurological, neurodevelopmental, and growth issues should be done. The child should undergo neuro-ophthalmological examination, clinical assessment for scoliosis, bone deformities, and fractures, evaluation of the endocrine system. Children with plexiform neurofibromas and optic pathway gliomas, as well as with other kinds of tumors, should be probably evaluated more frequently, including imaging studies. It is very important not to forget family support, which should be done by a social worker and psychologist. In adults, the surveillance recommendations are similar, but with a special accent on the clinical features typical for the adult age. If the patient has no optic pathway glioma, the neuro-ophthalmological examination may be probably done every few years, not every year. Cutaneous and subcutaneous neurofibromas are very common in adults, and their number usually is rising during life. So they should be evaluated clinically at least once a year. It is important to assess a big plexiform neurofibromas both visually and manually, and consider imaging studies like MRI and PET, both for surveillance and in every case of suspected malignant transformation. Neurological and neuropsychiatric evaluation should be a part of the annual clinical meeting. Blood pressure should be measured to rule out early hypertension and pheochromocytoma. Osteoporosis and increasing scoliosis should be evaluated annually. Due to increased incidence of breast cancer in NF1 patients, it's recommended to send young women for annual assessment of breast surgeon and considering imaging studies like ultrasound, mammography, and MRI, starting from the age of 25 to 27 years. About half of the NF1 patients demonstrate impaired social skills. So it's recommended to discuss with the patient issues related to their social life and to involve social worker and psychologist if needed. I want to say a few words about the imaging studies in NF1. Both in children and in adult patients, imaging studies not based on the use of X-ray are usually recommended due to an increased risk of radiation-related tumors and malignant transformations in NF1. So I believe that CT scan not should be used as a routine examination in NF1 patients. In addition, imaging studies should be clinically oriented. Currently, there are no recommendations for so-called screening neuroimaging in asymptomatic patients. In patients with big plexiform neurofibromas, whole body MRI may be considered for the evaluation of body tumor burden. FDG PET-CT may be used in cases of suspicious malignant transformation of plexiform tumors. The transition from pediatric to adult surveillance in NF1 may be challenging due to objective structural differences between pediatric and adult care. In many care systems in the world, medical services are more accessible for pediatric patients, and there may be significant differences in insurance policies for children and adults. A main care provider in childhood are parents, usually, and they're heavily involved in clinical decision-making. In adult population, the patient itself is usually responsible for making decisions and achieving the optimal medical care. Not a few NF1 patients are lost in adulthood and suffer from insufficient or not qualified surveillance. The transition to the adult care should be initiated by the case manager between the ages of 18 and 21 and needs a close cooperation between pediatric and adult specialists as well as social work and intervention. So this is the last slide. NF1 is a multi-system disorder, and clinical management of NF1 patients requires knowledge not only in neurology, but also in many other clinical areas, and especially important, a general clinical view on the patient. Unfortunately, the diagnosis of NF1 is often made by family physicians not experienced in neurofibromatosis. Many cases are missed or diagnosed in advanced stage. Different clinical problems of NF1 patients are often treated by different specialists in different hospitals, not related with each other. There is no real case manager for the patient available. So we believe that NF1 patients should be treated by a multidisciplinary team led by an NF1 specialist, usually neurologist, but not other possibilities are also possible. Also exist in tertiary NF1 centers. So thank you for your attention.
Thank you very much. It's a really nice overview how this should be organized in these patients. So now we have approximately 15 minutes to answer the questions from our audience today. I was mentioning the first one already. It was from Dr. Fakak. I think it was addressed to Shlomi. What do you think, Shlomi, about the use of endoscopic ultrasonic aspiration in OPGs?
Well, it's a very technical question. If you use the ultrasonic aspirator through the endoscope, you can appreciate how cumbersome it is. It's more difficult than what you see in presentations and in meetings. I think it is reserved for small tumors inside the ventricle, which are relatively avascular. Most of the OPGs will bleed if you just use an ultrasonic aspirator. So I don't say no, I just say choose your patients very cautiously.
There were more questions from the audience. There was one from Essam Ibrahim, if the Tel Aviv classification of OPG is validated and if there's any evidence for that. So
well, that's a fantastic question. And I'll tell you, my confession is that my paper on Tel Aviv classification is sitting on the right upper side of my desktop, and I've never brought it to the next step because of this validation issue. I feel uneasy to put it down just as a proposal. And because of this terrible heterogeneity, it is very difficult to validate. It's only a way to have a common language when we speak about an OPG to understand that by fragmenting the questions, we can perhaps collaborate better on subsegments of OPG. This is why we did the paper on optic nerve separately. We did the paper on adult separately because it's very difficult to mix the other tumors in terms of prognosis and treatment. But it's an excellent question.
And I guess this is the main base for this classification is the experience that you will have gained over the year. So this classification in your setting obviously works, or is it?
Yes, yes, I think it's true. It's true. It's nice for me to stratify a patient. Yes, posterior involvement. Yes, optic nerve involvement. Age. Yes, NF. No NF. And molecular marking. And then the chiasm goes in four stages.
Yeah.
But whether it's validated, no. Whether it helps me to stratify the patients, yes.
Yeah. Okay. Thank you.
Yes, and we have another question to you, Shlomi, from Daniel Nilsson from Gothenburg, who is asking whether laser ablation is a treatment option
Yeah.
in these students.
Yeah, well, as you know, laser ablation is reserved for deep-seated, rather small lesions that are growing, usually enhancing. It seems to be working well. It burns the tumor. Maybe it does more than burning the tumor, and the morbidity is very low. So I think laser ablation is one more option in the armamentarium that we have for deep-seated small tumors, and especially because of the focused radiation phobia in NF patients, maybe its role is even higher than in a regular patient. So the answer is yes.
You have any experience with laser ablations?
Yeah, we've done a couple of cases. Of course, it doesn't suit the big OPGs, anything more than a centimeter and a half. I see, George, you're nodding also. It doesn't suit the classical OPGs. And also, I would not stick an electrode inside the chiasm to burn it because it is involved with the apparatus of the vision.
Shlomi, it's George. I was going to ask you, so your cutoff is about 1.52 centimeters, correct? For the laser.
Yeah, I would say 1 centimeter. Sometimes we are tempted to just burn the center of a 2 centimeter. Sometimes the periphery will fall inside and you gain a few more years. So maybe the biology changes. What do you think?
No, I agree with you personally. I mean, I don't recommend laser ablation for any tumor larger than 2 centimeters. And I'm very cautious and hesitant for the OPGs, given the the location, proximity to the optic chiasm, and the potential for cyst formation. And swelling that's associated with it. So I don't have much experience with laser for OPGs, but for deep-seated tumors, our cutoff is 2 centimeters. Very strict on that.
Yeah, agreed.
There are more questions from Sebastian Fischöder. So he wants to know, I guess this is for basically all of us, and especially for Justus and the PN group. Do you always do genetical testing for NF if you have a peripheral nerve sheath tumor, multiple meningiomas, or bilateral vestibular schwannomas? So I don't know if Justus is with us. I can speak for the peripheral nerve part of this question. So if this is just one solitary schwannoma, neurofibroma, or whatever, we don't do it. Because our experiences, especially in the segmental neurofibromatosis, type of fibromatosis, especially if the limbs are affected and not the gonads, we will not have any result. So some groups send the tumors to have not just histology, but also genetical testing. And they found differences in especially in the schwannomas of NF1 and the so-called sporadic group. But basically, we don't know if any sporadic, so-called sporadic schwannoma or peripheral nerve tumor is basically something like a segmental type of tumor. Justus, you're there.
No. So I totally agree. But there are clear guidelines for this, right? So if you have 2 neurofibromas, then you shoot. If you have 2 schwannomas, then you shoot. You can always, if you have segmental schwannomatosis, you can look at the genetic makeup and see if they're not in one nerve. You can look at the mutations, and if they're the same, you have also LSD1 or NF2. So I would advise to look at the guidelines and then and use that, because they're for all these types of neurofibromatosis, you have clear guidelines which many people really study on and give their best. So I think you should use that. And
Yeah,
if you have
the
more,
question was if it's one tumor only, not at least in the peripheral nerve. I think
no, but also if they have a meningioma and a schwannoma peripherally, then you have a chance of NF2. So I think that's already in the inclusion of doing genetic testing.
Yeah, but if you just have a patient with one schwannoma and nothing else, you do them genetic. I think that was the question.
Oh no, never. No, if they're
Yeah,
one schwannoma, no testing. Yeah.
Okay.
Yeah. We've added another category in our NF meetings. The category is called maybe.
Yeah.
Because you have the classical patients on which there's no question, and occasionally you have a patient that you wonder if there is mosaic, or whether he's not an NF patient and it's a sporadic neurofibroma, or you have a patient with a little bit of enhancement of the optic nerve, but not more than that. So we call them maybe. We classify them under maybe. Some of the maybes evolve into full-blown disease, and some stay as a maybe. And sometimes we clear them up and say, okay, go, you're released.
Well, I think one of the major problems in NF1, or well, in both any kind of NFs, is the decision making. I mean, all the talks pointed out that to have a decision in a single situation when you just once saw the patients, almost impossible. I mean, there's some clear cases that have pain or whatever, and they want to have removed something, but I think the key is, at least in our experience, is 2 things. The first thing is to see them over time and to see them not alone, but to have a team that is working with you, because everybody has different perspective on these pathologies, and I think these other perspectives are really necessary to truly have the best individual treatment possible. I don't know if you agree on that.
Yeah, sure. So what's really important also for the NF1 group, for the peripheral the plexiform neurofibroma, you now have a game changer, the MEK1 inhibitor, which can really change your perspective of, like the neurologist or oncologist can see a patient and say, this thing is inoperable, and then start treating. And that's new, because formerly they just send them to us and we say, okay, we can operate or we can't. So it's good to see them together or discuss them in a multidisciplinary group and make decisions based on shared opinions.
It just takes so much time.
Yes.
So much time, this multidisciplinary clinics, huh?
Yeah.
And we suffer. We try to lump them together and just do them one tuck, 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 but it takes a lot of time.
It's a demanding group indeed.
Yeah.
Okay, I cannot see any more questions from the audience, and we've almost up to the time, so I think we can round up if you agree. And I would personally like to thank you all for your efforts to share, for your time, and your willingness to share your expertise, because it's a really difficult topic. We only touched some of very few aspects of these complicated diseases, but I think it was very nice. And just to remind our colleagues in the audience that all these webinars are posted both in EANS Academy after a short while, and of course in ISP and library, as you said. So thank you very much for my part. If you want to say something, Christian, before we close.
Well, I can just repeat your words. I completely agree. That was a fantastic session, and everybody is busy enough to sacrifice time to do this. It's always very much appreciated. So thank you very much. And yeah, thank you to EANS again, and to Radek to do this together. That was fantastic experience, and I think it's a good way to go.
Perfect.
Yeah.
Thank you so much.
Thank you very much.
See you soon.
Thank you.
Bye-bye.
Thank you,
Thank
guys.
you all. Have a great evening.
Stay well. Ciao.
Bye.